Today, we will be talking on dedicating ourselves on the World No Tobacco Day. And it's a really great privilege to talk about tobacco and the importance of tobacco. Today, I don't want to talk about tobacco just for doctors and healthcare workers, but it's also for non-healthcare professionals, families, relatives. And I try to explain the slides or my presentation today for all the people who's going to listen to this to gain some knowledge, to gain some understanding, and to spread the word and awareness to every single person. So that is one of the main things that we want to address today, to bring awareness, and it can be done by anyone. It doesn't have to be a healthcare professional or doctors. So relatives, families, kids, everyone should bring awareness and be aware of what's tobacco and the harmful effects of it and how we can prevent it for the future. So I want to start on what is this tobacco. So tobacco epidemic, we know, is one of the biggest public health challenges the world has ever faced. And unfortunately, there is a 1.5 billion tobacco users worldwide. And it is in every 4 seconds that we see that tobacco is being responsible for another premature death. So World No Tobacco Day, it was created in 1987 to help draw attention worldwide about tobacco epidemic and help us do preventable in terms of morbidity and mortality. So this year we are campaigning to mainly focus on the impacts of tobacco and in the environment. So according to WHO, there is 22K tons of water, 600K trees are chopped down to make cigarettes, and 84 tons of CO2 being emitted, which are released into the air, raising the global temperature. So there are 3 types of tobacco users. So one is the conventional tobacco products, such as the cigarettes, smokeless tobacco, and water pipe tobacco. So tobacco in any form is very deadly, whether smoked or unsmoked, and it contains more than 7,000 chemicals, including some known to cause cancer. Furthermore, secondhand smoke has been linked to several adverse health outcomes, including death. And so tobacco consumption usually begins at a very young age, leading to early onset of tobacco-induced health sequences and doubles the risk of early death. So I want to highlight here that the fact that it's beginning at an early age is because peer pressure is always affecting these young teenagers to feel like they need to be part of the cool popular crowd, as well as the industries are always trying to target this innocent, naive population to encourage them to get into tobacco usage. So they're unaware of all these health hazards that is coming to them by using tobacco. So for the patients or any person's lungs who are still growing, this tobacco is among the youth increases the risk of reduced lung function, impaired lung growth, and early onset of chronic respiratory disease. So another type is the heated tobacco products. So these are like all other tobacco products. So inherently, the toxic, they're going to be containing these carcinogens. And so this exposes the users to toxic emissions, many of which causes cancer. So these health tobacco products are tobacco products that produce aerosols containing the highly addictive substance, nicotine, and toxic chemicals, some of which is inhaled by the user. So currently there is no evidence to demonstrate that these heated tobacco products are less harmful than conventional tobacco products, and they contain chemicals not found in cigarette smoke, which may have associated health products. So here we can see the different types of tobaccos. It brings us a lot of awareness that tobacco is not only in a cigarette form, but it can be in other kind of formats as well. So we need to bring awareness of what types of tobaccos are being sold in the public. Another type is your e-cigarettes. So these are electronic nicotine delivery systems and your electronic non-nicotine delivery systems. And they are referred to as e-cigarettes. And these devices, they actually heat the liquid to create this aerosol. that is going to be inhaled by the user. And so even though they don't contain the tobacco, but they're still containing this nicotine and toxic substances that ends up being very harmful to the health. So some cigarettes may also be reported to cause serious injuries. So these are your burns and fires and exposures. So this is something to be very cautious of. So now what can we do? So today we're talking about No Tobacco Day. So what can we do as healthcare professionals and doctors? And even if you're not a healthcare professional, how can we contribute to our family and relatives? Well, here is one day we are dedicating to bring awareness. And it doesn't have to be just today, it can be any day, that we need to be constantly bring awareness to our younger population and make them feel that there is a point. You know, we sometimes feel like, okay, keep telling them there's no point, they're not changing their behaviors, but we cannot give up. We need to try and make a change and implement the strategy. So one effective way of implementing the strategy is to do a plan, do, study, act. So what we're doing is we want to sort of talk to the patients or the person who's having tobacco and sort of describe objectives and ask them, okay, is there any steps that we can be with them to help them and make a plan approach towards deciding, you know, to quit smoking or reduce the number of cigarettes. And then we want to do that plan with them and see, you know, how effectively they're doing it, or is there any failure in that? So we're going to be doing it and studying with them and analyzing the data that, okay, how effective the approach is there things that we need to change and act upon it and see that, okay, is there something that we need to improve ourselves next time after we conducted the study and act upon it. So a few years ago, the WHO actually developed this powerful thing called Empower, okay? And Empower, it had these 6 keys of trying to be most effective strategies for fighting global tobacco epidemic. So the first one is monitoring tobacco consumption and effectiveness of preventive measures. So that is, many research is now trying to be observing the patients and tobacco usage and how they're being absorbed and how is it worsening the epidemic in terms of cancers and illnesses from that. So this is bringing us awareness on it by monitoring the tobacco consumption. Then we want to protect the people from tobacco smoke. And this is including those who are not even tobacco users. So people who are asthma users and pneumonia, bronchiolitis, and your lung cancer are from secondhand smoking, and they're going to be more vulnerable to this tobacco smoking, even though if they're not smoking. Now, amazing thing is a lot of schools and universities and colleges are trying very hard to make their campuses smoke-free campuses. So this is a great initiative. There are some other shopping malls and movie theaters who are trying to make that as well. And then you want to be the people in support to help them to take those first steps to quit tobacco smoking when those patients realize that it is time to make that step. And then you want to warn about the dangers of tobacco, give them some information and understand what they're impacting themselves with by having tobacco, and then enforce bans on tobacco advertising, promotion, and sponsorship. So this is a great way to say that, let's say we are going for any conferences that are being sponsored by tobacco companies. So by going there, you're supporting that. So you can try to bring awareness to your colleagues and, inform them that, I don't think we're doing a great job of going to a conference that is being sponsored by tobacco companies. So try to promote ways to reinforce banning and getting those kind of sponsorship. And the government is doing its job by raising the tobacco taxes as well. So another thing I want to highlight here is it is a younger generation that we're always worried about. And unfortunately, flavored tobacco is something that they always try to appeal to younger generations. And as parents, as siblings, as families, or even as doctors or health workers for our patients, we need to inform them that, you should not, buy anything that has favored tobacco products for the youngsters. So this is really important to emphasize. So in terms of smoking, we know that it is very important in terms of our exams and our academics as well. So because we know that smoking affects the systems in the human body and it's a risk factor for many illnesses. And so a thorough knowledge about smoking can help ace the USMLE exams. So in pediatric smoking, it is known as a major risk factor. So it can be there in intrauterine growth restrictions, abrupto placentae, placenta previa, sudden infant death syndrome, and neonatal polycythemia. So other risk factors we should keep in mind is, of course, COPD, any strokes from cerebral vascular accidents, peripheral artery disease, like you can have Burgess disease, aortic aneurysm. So this is going to make the lumen become very thinned out and weaken it. Impairment of wound healing. So that's how we can get the gangrene occurring. GERD as a reflux, post-operative pulmonary complications, and then transfusion-related acute lung injury and osteoporosis. So here I want to just point out the adverse effects that we know that smoking exposure can occur. So with smoking, it can affect at the molecular level by inducing more cytokines and chemokines, inflammation, and monocyte recruitment, protease and antiprotease imbalance. And then it works at the tissue response by making more goblet cells becomes hyperplasia, impairing your mucociliary clearance, tissue destruction, and collagen deposition. So this is just the underlying stuff which we cannot see, right? But what we are working on is making awareness of this organ response. So all these organs, they get remodeled, have chronic inflammation, they can get fibrosed. That's what we're seeing clinically, the changes happening. And then these patients are coming to us with lung disease, COPD, with chronic bronchitis, emphysema, small airways disease, and increased susceptible infections and air pollutants. So here is what we are always seeing. And this is what a lot of the times patients need to be aware of, that what is the outcomes going to be occurring on taking chronic smoking. So smoking can also, we know, affects your coronary heart disease, and it is a modifiable risk factor. So this is an amazing thing that we can modify a risk factor, and we must take that opportunity. So most studies have shown that the most significant increase in CHD risk is patients smoking more than 1 pack daily. So the risk of these cardiovascular events actually declines with smoking cessation and approaches to a non-smoker range in 2 to 3 years. So this is an amazing result that we can make a change, that if we can influence patients to reduce their smoking, okay, to less than half a pack, and then reduce that to complete cessation, we can make a difference in patients' life because it's modifiable. So another thing is that we know smoking is going to be affecting everything, okay, not just the lungs. Yes, you have your oropharyngeal, nasopharyngeal, laryngeal squamous cell carcinoma can happen, esophageal cancer, lung cancer. So these are very common because we're smoking as we're having it. But the other organs are also having victims to this smoking. So you have your gastric cancer, pancreatic, oral, colorectal, renal, bladder, cervical, and valvular squamous, and the list doesn't end here. So in terms of us healthcare professionals, we must think about screening always. So for lung cancer screening, we must screen those patients of 50 to 80 in more than 20 pack years smoking history who are current smokers and quit in the last 15 years. And we have to do the low dose CT scan every year. Abdominal aortic aneurysm screening. So we remember that this is also important, that smoking can weaken the lumen and can increase the chance of aneurysm. So men are more vulnerable to this, especially the ages of 65 to 75 with any prior history of smoking. And so we have to do a one-time abdominal duplex ultrasound on them. So after knowing all this much of things, I want to present to you something that will make you understand the cases. So I want to bring you forward a patient who I knew and was vulnerable to this case of taking tobacco. So he was a 54-year-old man, and he came with difficulty in swallowing to both solids and liquids. So initially, in the first 4 months, he was difficulty in swallowing to solids, and later progressed to liquids in the last 2 months. And he had a lot of weight loss. He had also other histories of heartburns, nighttime coughing. He was more tired, fatigued. And this is most important thing, that he was smoking for 30 years. And he's someone who was very jolly and used to love, eating food and enjoying life. But he had this smoking history. And he was pretty obese, so you can say that, being a very fun-loving husband to his family, he was doing great until his presentation came with the symptoms. So what is our differentials that we can keep in our mind, right? So in our differentials, we can always think, okay, could be a benign reason that he's having the structural obstruction. So it could be a web or rings or stenosis of the esophagus, but these will be more like slowly progressive, and so the patients will modify the diet to help them swallow, and they'll have a maintained weight, which was not seen in this patient. It can be because of functional causes like your nutcracker esophagus or diffuse esophageal spasms. So here we'll see uncoordinated or dysfunctional contractions of the smooth muscles, or it can be because of esophagitis, like any infectious cause like candidiasis, herpes simplex, and CMV. But he was not immunocompromised. Or we can think about the non-infectious causes. So he did have a history of reflux. So it could be because of GERD, or it can be eosinophilic esophagitis, but he was not a young male with history of allergies. For that, we should do a biopsy to confirm that there's a lot of eosinophils throughout the interesophagus. Also, dysphagia can also be seen in achalagia primary being the most common, but sometimes dysphagia can be seen in pseudoachalagia, which will show presence of mechanical obstruction, and that can suggest as malignancies that can mimic the achalagia. So malignancies of adenocarcinoma and squamous cell carcinoma. Okay, so now with our differentials, what's the next best step that we should do in our investigations? So we should think about doing an X-ray, and in an X-ray we'll see like a widened mediastinum. Okay, so yes, we may think, okay, that sounds to be something might be there in my esophagus, right? So I want to see what could be there. So what's my next best investigations? I need to do an endoscopy. Okay, that's going to help us see if there is any tumor, mass, or anything that is causing this dysphagia to be progressively worse in the 6 months. So the endoscopy is the best complementary test, and it's the best initial step and gold standard in direct visualization and taking a biopsy. So for this patient, once we biopsied him and we saw an endoscopy, he actually had a squamous cell carcinoma, and we were able to stage it by confirming it. We can, some patients can also have adenocarcinoma as well, but it depends who has what, and for that we should differentiate them as well in our mind. So the squamous will be in the upper 2/3, whilst adenocarcinoma will be in the lower 1/3. Both has smoking as his biggest risk factors, but if you guys see that smoking is 9-fold increase in squamous compared to the 3-fold increase in adenocarcinomas. So squamous will also have alcohol, achalagia, hot liquid beverages, and causatic strictures, diets such as nitrates and nitrosamines, and your radiotherapy surgery. Whereas adenocarcinoma, we can also have obesity, chronic GERD, and Barrett's esophagus. And adenocarcinoma more happens in US, while squamous happens more in the worldwide. Both will have males being more vulnerable to females, and the Black people being more affected than the white. Older age is more affected in 50 to 60 years of age compared to the 60 to 70 years of age in squamous. And looking at these, there could be very many overlaps. But our main thing is confirming the diagnosis and then looking for other stages. So why not do barium swallow? So barium swallow, it can be used when we feel that there is some contraindications to using endoscopy. Like if there's a stenosis or strictures that's not going to allow us to put an endoscope through it, we can then use a barium swallow. And when we do, we will see irregular asymmetrical borders of the esophagus and stenosis of the distal end and show us this apple core lesion. Okay, so once we have our initial diagnosis in mind, then we want to think about staging. So the staging will be done by looking at the CT scan. So we want to do the chest and abdomen to identify and locate, has there been any metastasis? And if it does not show metastasis, then we want to keep up doing a PET scan in mind, which could show us more diagnostic accuracy. So we can also do an ultrasound, which is going to be having a transesophageal endoscopic ultrasound, and that's going to help us to see for any regional lymph nodes. And with that, we have a good scope of doing a fine needle aspiration, FNA, to identify that has any metastasis gone into the lymph nodes and identify based on that. We can also do a bronchoscopy that's going to help us to stage any lesions at or above the cornea to rule out any airway involvement. And lastly, we can do a laparoscopy to increase the accuracy of detecting any small liver metastasis. So now we looked at this patient and we see, what his diagnosis is. So we know that his biggest risk factor is tobacco smoking. So what can we do as doctors? So of course, our role will be to counsel patients, looking at the patient while they grieve or deny the acceptance of the diagnosis, talk about the management and prognosis. And we want to sort of encourage them, even if they're diagnosed, even if it's an end stage, we still want to encourage them from reducing the smoking inhalations, from reducing the intake of smoking. So one thing is, it's an impossible task to do abrupt stoppage of smoking, right? And along with this, we need a lot of support. So we need to integrate a lot of healthcare interdisciplinary teams, a lot of family support and social behavioral support to encourage the first steps in reducing the smoking behavior and working methods to help reduce the temptation to smoking by using alternate methods. Also, we want to educate the people in all generations and age groups so they can bring that awareness. So the main thing is when they say educate, it means the families. These patients will be dealing with the grief and wondering what's going to happen next, but it's a family support who needs to encourage them and be with them that yes, they can do it. They can stop smoking, they can reduce smoking, even with the whole diagnosis and prognosis. So I want to bring some research in how awareness is being projected to statistical ways. So one research talked about smoking reduction interventions and cessations. And we asked these patients to stop smoking. And we found that it was very hard for these people to just suddenly quit smoking and cut it down completely. So then we had to work ways to cut down the smoking by using varenicline or nicotine replacement therapies, like gums and lozenges. And then we sort of used medicines to help them. And then main thing is the face-to-face support, because once they can see that, because once the breakdown from smoking, it's a lot of support is needed to talk to about it, to feel and have other people going through the same journey and be there for each other. So this is a very important, vital thing, the face-to-face support to cut down the smoking and help those people to quit if they're provided with more self-help materials to cut down themselves. So that's very important. Another thing in research that has been used is the importance of smoking has actually decreased the risk in esophageal squamous cell carcinoma. That makes a big difference. that we know that smoking is contributing to both these risk factors in squamous and adenocarcinomas. Although smoking cessation did not make much of an influence in adenocarcinoma, but if you guys remember, squamous cell has a 9 times fold increase compared to adenocarcinoma. So if we can make a difference in reducing that by reducing smoking and decreasing the risk of squamous cell, then we can make a difference. So now this patient, what is our treatment and prognosis? So, well, in these situations, if there's locally invasive disease and has not invaded any kind of surrounding structures, we can actually do chemotherapy, which will help to have a complete response to it. And next thing is doing a surgical resection. We can do an endoscopic submucosal resection that will remove the superficial epithelial cells, or subtotal or total esophagectomy that will remove any colonic interpositions. If patients, there's metastasis or advancement of the disease, then palliative care is what we need to focus on, and we have to give them chemoradiation or place a stent or do other endoscopic treatments of laser therapy. Now, as I was mentioning, prognosis is a very difficult thing because most of the time these patients come to us with the clinical features at a very much late stage in the diagnosis, at the time when it's already become very progressive and might have metastasized. So to lose a patient in such a terrible way is very painful as a healthcare professional, as a family. And so we can help bring that awareness and reduce that smoking and save that life. So now we had my case presentation on esophagus. I want to bring you guys one more to make you guys understand that smoking is mainly also affecting those patients who are smoking in the lungs. So we had this another gentleman. He came as a 54-year-old patient, and he was coughing a lot and having a lot of bloody sputum. He had weight loss, anorexia, constipation, a lot of thirst and fatigue, and he smoked 2 packs of cigarettes daily for 32 years, okay? Very similar to the other presentation. In these presentations, we saw that the calcium was very high, and we decided to do an X-ray, and we found there was a HeLa mass. So what is our differentials? What's our diagnosis? Most likely lung cancer. And as we saw that lung cancer can be seen in primary or as a second-hand cigarette smoking, and or even followed by a prior history of radiation therapy and other toxic exposures such as asbestosis. So squamous and the small cell, they're the ones who are centrally located, whereas adenocarcinoma, which does not affect smokers, are peripheral, along with large cell, which are also peripheral. So unfortunately, squamous and small cell, they are the most aggressive forms, and they're centrally located. So in this form, we can see the adeno in the adenocarcinoma in the peripheral, where small cell in the central areas. Same thing in pathology, we can see it more in this periphery, whilst squamous small cell will be also in the central area, okay? So now the interesting history begins, that initially in the 1970s, we actually used to have squamous cell carcinomas being the most common type. Now, what happened is these manufacturers, they decided to change the types of filter being vented into these cigarettes, and allowing the smokers to draw in smoke even more, allow deeper inhalations. But unfortunately, doing so, we started to introduce the history of adenocarcinoma subtypes being exposed. And we start to have more of these cases compared to squamous cell. So we know adenocarcinomas, as this occurring, the smoke is actually occurring more distally towards the bronchoalveolar junction, where the adenocarcinoma starts to arise. So yes, the manufacturers started to change the methods, but it also caused a new subtype to start appearing. So smoking, we know, is there's like 20 potential carcinogens of 3,500 chemicals and is detected in those who smoke. And it's established with the polycyclic aromatic hydrocarbons and N-nitrosamines. And they also contain high levels of acrolein, which is toxic to the ciliated lining of the lungs, and other agents such as nitrogen oxides, acetaldehydrates, phenols, and formaldehydrates, which all contribute indirectly to pulmonary carcinogenicity in everyone, including animals. And also the free radicals can also induce oxidative damage in animal models as well as humans. So patients with lung cancers, they can come with the coughing, hemoptysis, weight loss, dysphagia, hoarseness, chest pain, and they can also have physical exam of tachycardia, tracheopnea, pallor, lymphadenopathy, decreased or absent breath sounds, wheezing, and clubbing. So now, what is our ways to diagnose this? So we'll do the complete usual labs of CBC, do the CMP of electrolytes and other tests. We'll do an X-ray to see if we can see any nodules of lung nodules appearing, and do a low-dose CT scan to diagnose and stage it if it has spread anywhere. And we always want to compare any prior X-ray or imaging to see that is this a new incidental finding of a cancer or a nodules or something that was there before and is kind of growing kind of more now. So that's very important to ask and do a comparison of prior imaging. So now the treatment, a little bit of this we sort of discussed on the prior present slide on the research, that nicotine replacement therapies, they can be your patches and gums. And also you have your varenicline and your bupropion. So these should be, of course, added with counseling and a lot of supportive therapy. Now, treatment for these patients after we stage them, so this could be after doing your X-ray CT and then doing PET scan to see for any kind of metastasis and doing a biopsy to confirm what kind of cancer it is. You can do surgical removal provided is localized. We may need to do radiation, chemotherapy, or combination of all of these, and treat any paraneoplastic syndromes that may be associated with that type of lung cancer, and always be supportive to this patient's journey. So complications, lung is known to have a lot of metastasis to common sites of the liver, the brain, adrenals, and the bone. They can have associated pancreas tumor by having Horner syndromes. They can have hoarseness by compressing the laryngeal nerves or any nerves that is nearby. Superior vena cava syndrome can also occur by compressing the superior vena cava, and paraneoplastic syndromes can be also seen. So paraneoplastics, so we know that small cell lung cancers, you can have SIDH, and you will have the euvolemic hyperosmolar hypernatremia. You can also have ACTH, which is going to be ectopic in Cushing syndrome, and the Lambert-Eaton syndrome. So other thing is squamous cell carcinoma. So in this patient, we saw the hypercalcemia, if we remember, and this could be secondary to your parathyroid, the PTH-like peptide. Large cell carcinomas, they will have the prolactin-like effect that can be seen in galacturia and gynecomastia. And lastly, you have adenocarcinomas. So these will not be seen on the central, will be seen peripherally, and usually affects those who are, even though they're not smoking, but they could have clubbing like this, and hypertrophic pulmonary osteoarthropathy can be seen in them. So now again, to bring clinical research onto this and the importance of smoking reductions. So prevention of your tobacco use and cessations are always primary ways, right, to prevent lung cancer. But even after diagnosis of lung cancer, smoking cessation is the most important in improving the survival and quality of life. So even if these patients are diagnosed with lung cancer, even if they're at a worse prognosis, still it's never too late to improve the quality of life by reducing smoking. So effective treatments are always available to help those who are smoking and are willing to quit. And persistent efforts are often repeated with contacts that may be necessary to achieve the long-term cessation. So always being supportive, always working ways to help and encourage those patients to make the first step in reducing smoking. Another research also promotes the importance of smoking cessations, which broadens the impact of any lung cancer screening. So the importance of screening, we talked about this as a healthcare professional, is well beyond the endpoints of cancer diagnosis and cancer mortality to reduce risk from many other diseases and can positively impact many other patients than the small percentage that they have cancer. So it's important that we also do lung cancer screening when the patient comes to us. And I want to also emphasize, of course, the benefits. So yes, I've been talking to you all the time, the importance of stopping smoking, and we need to quit it right now. But we also need to encourage you that if you stop smoking, what is the benefits? What's the improvements that you'll feel? You will have an improvement in oxygenation. Your blood pressure is going to improve. You don't have to take 2-3 antihypertensive medications. It will get lowered. You'll improve your smell, taste, circulation, breathing. It will increase your energy, improve your immune response. And of course, the long-term benefits that you do prevention to your disease progression and reduce the risk of synchronized multiple primary lung cancers and tumors and prevent other organs from being affected. So lastly, I want to work on the 5 A's of tobacco dependence treatment. So you always want to ask each patient at any time of contact if they smoke tobacco. And you want to assess the patient's readiness to quit. You want to always advise all smokers to stop smoking. Assist those patients who are reluctant to quit. So these patients are the pre-contamination and contamination patients, and educate them and motivate them. And even at this time in your visit, they're not willing and ready to do it. Ask them the next time you follow up. Ask them the time after that you follow up, just to keep reminding them that you are there for them, that that is something that you want them to think about as they walk away from you. So it's something that you always want to assist them, educate them, bring more information, try to bring up the statistics to bring awareness into the mind, and then arrange for follow-up or visit and referrals for any additional resources such as smoking support groups. Don't leave them alone thinking that it's pointless not to help them. You may make a difference, if not today, but maybe 2-3 years down the line, that they may change their mind. So it's never late to keep trying. So lastly, I also want to work on the COVID's impact on our lung cancer patients. So of course, this past 2 years have been very detrimental to all of us in losing somebody or the other we have loved. And these patients, most vulnerable, apart from immunocompromised patients, were actually lung cancer patients. And when the infection has started, there was actually a lot of higher morbidity and mortality for these lung cancer patients. And because we didn't know much about the infection, how did it infect and how it was causing it, a lot of these lung cancer patients were actually deprioritized to the ICU admissions and mechanical ventilations. And that way we lost many patients. And we found out that with research that those people who were lung cancers, based on their clinical features and baseline, they had a lot of age, of course, the more age. And the main thing is looking at this is the smoking history. So when we look at the people smoking, we see that they're actually more compared to everyone else with the worst outcome. And we can see that it had a higher odds ratio. So compared to COPD, hypertension, and this actually is very interesting because you would expect, people with radiation or any surgery, COPD, hypertension to have a higher risk of mortality, but actually it's people who smoked that caused worse prognosis and outcome in survival. So this makes another impact why smoking can be so dangerous to any patient's health, especially with COVID still being existent. So what is our duties finally? That we always want to educate on lung cancers, not only on our patients, but ourselves, our families, relatives, children, next generation, mostly also to our colleagues, because with a lot of stress, our colleagues can also go and fall to become the victims of smoking as well as the stress piles on. So you want to also be there for them to work on this first step as smoking. Just because we are health professionals does not mean we are also patients. So we also have to remember in helping each other to make that first step in reducing the smoking. And we want to bring awareness to all the patients, to everyone, even though there's nothing new. Smoking has been happening for years, for almost 50 years, and it's always been seen in movies and in the advertisements. So nothing is new, and we may feel it's helpless to do anything about it, to make a change, but we can always be a superhero with our red coats and always make a difference. Because yes, we may not make a difference today, but by persistent efforts, we can always make a difference one day, save one life, make a difference, and we should not give up. So it is our mindset that needs to be changed. And it's not just today because we're dedicating ourselves on No Tobacco Day, but it should be every day, because it will make a difference in all the patients who are suffering silently from the effects of smoking. I would like to thank you all for your patience in listening to me and bring awareness about tobacco and smoking. So I would say that yes, tobacco is something that we need to stop, but what we need to bring more awareness is that by reducing our stress and looking at tobacco as our best friend, we should need to burn our calories and work more of a better lifestyle and health, rather than looking for things like tobacco to help us cut down our stress. So thank you so much, everyone, for listening and for being there. And I hope you have learned something from me today. Thank you.